Hello, everyone. My name is Martin Campbell, and I am a second-year internal medicine resident at Emory University School of Medicine. The title of my presentation is Bridging the Gap to Optimal Dosing for Guideline-Directed Medical Therapy for Patients with Heart Failure and Reduced Ejection Fraction. The key to improving heart failure outcomes and its ultimate impact on reducing healthcare costs include the initiation, optimization, and maintenance of guideline-directed medical therapy in patients with heart failure and reduced ejection fraction. The ACC, AHA, and HFSA guidelines recommend maximum tolerated doses for these patients unless contraindicated. Despite knowing all this, there is still underutilization of GDMT at recommended target doses in eligible patients. So we hypothesize that the majority of eligible patients in our safety net heart failure clinic are on optimal doses of GDMT. For our methods, we conducted a retrospective analysis of GDMT in patients with heart failure and reduced ejection fraction seen in our heart failure clinic between January 1st and March 31st of 2019, in addition to completing at least 2 heart failure clinics during that year. The primary outcomes were the percent of patients on optimal doses of beta blockers, renin-angiotensin-aldosterone system inhibitors, and mineralocorticoid antagonists. Optimal dose was defined as at least 50% of the target dose or the maximum tolerated dose. If we look at Table 1, we can see the baseline demographic data for our patients. It included 227 total patients. 70% of them were male, 93% were African American. When it came to insurance, 41% were self-pay, and 53% were on either Medicare or Medicaid. 97% of our patients were hypertensive, 42% had diabetes, 37% had chronic kidney disease, and 61% were smokers. Average BMI was 33. The mean potassium level was 4.75 and mean creatinine level was 1.05. The mean left ventricular ejection fraction was 24%. 70% had non-ischemic cardiomyopathy and 11% were ischemic cardiomyopathy. 96% had stage C heart failure, and the average number of heart failure clinic visits was 12, and the average oral diuretic dose was 69 Lasix milligram equivalents. If we look at Figure 1, we can see that it shows the prevalence of GDMT use by drug class. 96% of our patients were on beta blockers, 85% of our patients were on RAS inhibitors, 32% of our patients were on MRAs, 83% of our patients were on both beta blockers and RAS inhibitors, and 27% of our patients were on all three. Figure 2 shows the percentage of our patients on optimal doses of GDMT by drug class. This red line demarcates the 50% of patients line as outlined in our hypothesis. If we look at beta blockers, 62% of our patients were on optimal doses. For RAS inhibitors, 56% of our patients were on optimal doses. And for MRAs, 91% of our patients were on optimal doses. For the patients who are on both beta blockers and RAS inhibitors, 32% of them were on optimal doses. And for patients on all three, 11% of them were on optimal doses. Figure 3 is an overlay between Figure 1 and Figure 2, and it highlights the number of patients on each class of GDMT compared to the number of patients on optimal doses. For beta blockers, of the 96% of patients who were on beta blockers, only 62% of them were on optimal doses. For RAS inhibitors, of the 85% who were on these therapies, only 56% of them were on optimal doses. 32% of patients were on MRAs, but 91% of them were on optimal doses. And for those on beta blocker and RAS inhibitors, 32% of the 81% of patients on this class of drugs were on optimal doses. And then for the patients who are on all three, we had a total of 22% of them, but only 11% of those patients were on optimal doses. So in conclusion, GDMT dosing in our safety net heart failure clinic was appropriate for patients on monotherapy, but suboptimal for patients on multiple classes of GDMT. Based on these findings, we are implementing a quality improvement process to facilitate early initiation and up-titration of GDMT in our heart failure clinic. Our study was limited by us not including data on hydralazine and isosorbide dinitrate, and the reason for this was inconsistent prescription patterns that were observed. Also, SGLT2 inhibitor data was not included because during the time of data collection, our health system's formulary did not include these medications. Our strength is that this study is one of the few that analyzed the utilization of GDMT in a predominantly African American patient population. Here are our references and disclosures. Thank you for your time, and that concludes my presentation.